good evening to our honorable faculty and MRCP Part 1 aspirants. Today's class is about mega mock test on endocrinology and oncology. Our today's faculty is Dr. Varun Pushkarna sir. He is a senior consultant in internal medicine at FORTIS Escort Hospital in Amritsar. Over to you, sir. Now you can proceed with your lecture.
Good evening, everyone. Good evening, doctors. So today we have a class on oncology and endocrinology. Both of them are like good topics, but endocrinology takes the lead. Uh, it's more read and more followed. But oncology is scoring. Scoring as in not many people read it. So they leave it to chance. So there's very few questions that are very important that come from oncology. If you are ready with them, then you are sure to make 100% scoring in those questions. So oncology is very important. So we'll start with the onco questions first and then we'll take up endocrinology. So in oncology, there are 2-3 topics which are more important that we usually talk about. One is the type of malignancies that are in syndromic manifestation. So like men type 2, men type 2A, 2B, that is like oncoendocrinology, that's combination. Then like Peutz-Jeghers syndrome, hereditary polyposis, they are associated with multiple malignancies in the same patient. So the number one important pearl for MRCP examination and attempting questions from oncology is remembering all the hereditary malignancy syndromes, all of them. Some of them are because of the loss of a protective gene. So one is loss of protective gene. So there is a gene which is lost, which is a protective gene. Like in a city, if there is a lot of criminals, the police suddenly is taken away. So the criminals will shine. So loss of a protective gene will lead to cancer formation. That happens in BARC and such syndromes where the protective gene is lost. And then there is a proto-oncogene. Proto-oncogene is which when gets activated will activate multiple malignancies. So like red gene. So when it is activated, this gene is like, if there is a mutation in that gene and the thing that is not letting it show off, it is removed, then the gene will show off and there will be malignancies elsewhere, everywhere in the body. Multiple organ systems will be involved. So these two genes, they are important from genetic predisposition to cancer point of view. So this is one type of question that will come in the exam, that is type of the malignancy, syndromic, hereditary malignancies, de novo, and their associations. Second question that usually comes from oncology is the side effect profile. If you remember, people keep remembering which drug is used in which malignancy. No, not at all. Nobody is going to ask you which treatment is preferred in breast cancer, in pancreatic cancer, in gastrocarcinoma. No. Nobody is going to ask you any question. Yes, they might ask you that in palliative care, what will you do? So in palliative care where you cannot do surgery, the only thing left is either, can anybody tell me what is the difference between chemotherapy, adjuvant chemotherapy and neoadjuvant chemotherapy? Anyone? So chemotherapy is when the option of treatment is chemotherapy, like in bone marrow. So we have a treatment of choice is different, but the initiating treatment is chemotherapy. The second is adjuvant chemotherapy. Adjuvant chemotherapy is when you give chemotherapy after you have surgically removed the tumor. That means you don't start with the chemo, but you perform surgery, you take out the tumor, and then you start the patient on chemotherapy. This is called adjuvant chemotherapy because primary treatment is surgical. The secondary treatment is chemotherapy. Then we call it adjuvant. Nowadays, we are using neoadjuvant chemotherapy. Neoadjuvant is when the tumor load is so much that the surgeon fears that the tumor surgery may not be helpful. One. Second is it might be more detrimental too. And third is outcomes, of course, they will not be as good. So neoadjuvant therapy is when you give chemotherapy prior to surgery, not to not with an intention to treat. The ITT, which is called intention to treat, is not there. The intent to treat is not there. Neoadjuvant chemotherapy means you just have to downstage the disease. Let us say patient has 2C, you have started chemotherapy just to bring it down to 2A or 1C, just to get the surgery done so that the tumor bulk is reduced and the surgery can be performed. So have you got the idea? Chemotherapy, adjuvant chemotherapy, and neoadjuvant chemotherapy. Okay. So so they can ask you question like this, but not that which drug is indicated where. Second question that can come is side effect profile of all the drugs: vincristine, vinblastine, cyclophosphamide, cisplatin, and so many of them. So we have this question coming from cisplatin. So there are a set of side effects that we see, that usually we get to see in these patients. So 46-year-old lady is receiving cisplatin based chemotherapy for lymphoma. So we should understand, the question is that there is a young lady, 46 years old, who has been diagnosed with lymphoma. Nothing has been given that he is non-Hodgkin, Hodgkin, or other type, but the treatment is cisplatin based. So right from the outset, you can make out the question is going to be about the effect and side effect profile of tumor, because they have not given much data. So just the cancer drug, they will ask question about it. Which one of the following is a distinctive side effect of cisplatin? Hemorrhagic cystitis, rhabdomyolysis, optic neuritis, ototoxicity, or cerebellar ataxia? Anyone? So the answer is, classical answer is ototoxicity. Let's see. Okay. So the typical side effects of cisplatin, they are marrow toxicity. Of course, it is a very aggressive chemotherapy which is used in hematological malignancies. So bone marrow toxicity, ototoxicity, peripheral neuropathy. Potential side effects are neurological in case of cisplatin. So platinum is a heavy metal deposited in these neurological tissues. Alopecia and change in taste along with nephrotoxicity. You see optic neuritis also somewhere mentioned here in the photo, but the mainly what you see the toxicity is ototoxicity and alopecia, very common. Alopecia is very common. People lose their hair on their head. Then mucositis, stomatitis, cardiotoxicity can happen. In hematological, bone marrow toxicity, nephrotoxicity, peripheral neurotoxicity. So optic neuritis is more of a central neurotoxicity. Cranial nerves are involved. So that doesn't happen. It's peripheral nerves which are involved. So that can happen. All right. Then the other thing that I want to highlight here is, please, you can turn your mics on. Tell me, hemorrhagic cystitis is side effect of which drug? $100. Yes. Cyclophosphamide. Yes, cyclophosphamide. Very good. Okay. Rhabdomyolysis is the side effect of which drug? Very famous drug. Okay. So rhabdomyolysis is statins. Okay. Very common is simvastatin. We use atorvastatin so commonly, no? In all the heart patients, we put them on atorvastatin. So if somebody is taking statins, they can be prone to develop rhabdomyolysis. Is that okay? Then comes optic neuritis. Which drug you commonly come across which can cause optic neuritis?
INH.
ethambutol.
INH. Antitubercular.
So somebody was saying ethambutol. What does ethambutol do?
It get deposited in the nerve endings, I believe so.
So basically the optic neuritis is not because of ethambutol, it is because of INH. Okay. And it is optic neuritis is basically INH dependent. That we see ethambutol is optic neuropathy. Have you got it? So there's two different things.
Yes, sir.
Optic neuritis, that is inflammation of the nerve, is with INH. The optic neuropathy is because of ethambutol. And the optic neuritis because of isoniazid can be prevented by peridoxine. Okay. Whereas the neuropathy that occurs because of ethambutol usually doesn't have a specific treatment. It can cause permanent vision loss also. Okay. Now, in case of neuropathy, there could be several factors involved. There is not just inflammation of the nerve, but then the function of the nerve goes away. Ototoxicity. Which famous drugs cause ototoxicity apart
Aminoglycosides. Amikacin, aminoglycosides.
Gentamicin.
Yeah. Anything else? Very common drugs. Loop diuretics. Okay. Loop diuretics. Usually people become deaf if you keep on increasing their dose of furosemide. These are the questions very routinely asked in MRCP. Cerebellar ataxia. Can anyone tell me side effect of which drug?
Vincristine.
Wonderful. So vincristine. Okay. All right. So we'll go to the next question. Okay. And now this question is from the concept that I just told you when we started the class concerning colon cancer. Very common cancer. You can actually put it on your fingertips which cancers are there, which are asked routinely in the exam. One is colon cancer. The other is breast cancer. Then, yeah, HCC is also asked. There are not many questions which are asked. Colon cancer is the most important one. Another cancer which is very important is skin cancer, melanoma. Then comes lung cancers, small cell and non-small cell cancers. So if you read these 5 malignancies, no, the onco thing is done for you. You can go and attempt an exam. So concerning colon cancer, which of the following assertions is true? One is that it occurs most commonly in the ascending colon. 2, it is a characteristic feature of Peutz-Jeghers syndrome. C, in familial cases, the inheritance pattern is typically autosomal recessive. 4, in non-familial cases, gene mutations in the cancerous cells are unusual. 5, in familial polyposis, the increased cancer risk is due to inheritance of a mutated tumor suppressor gene. Any idea? So we'll go one by one. Colon cancer occurs most commonly in ascending colon. Wrong. It is usually in rectum and sigmoid colon. So these are the most commonly involved regions in colon cancer. Then comes, is it a characteristic feature of Peutz-Jeghers syndrome? So what do we see? There are, in Peutz-Jeghers syndrome, we have hematomatous polyps. We have hematomatous polyps where So hematomas are there as looking as polyps in stomach and whole of the large intestine. So basically what we see, they are benign in nature. They are rarely malignant. So it cannot be a characteristic feature. Then comes the familial cases are typically autosomal dominant. So recessive. So यहाँ recessive लिखा है, but it is typically autosomal dominant. So ये भी आंसर गलत होगा. In non-familial cases, the gene mutations in cancerous cells are unusual. See, in non-familial cases, how can cancer come if there is no mutation? So mutation is a requirement, is a prerequisite to happen in case of de novo cancer if there is non-inherited tumors. In familial polyposis coli, the increased cancer risk is due to inheritance of a tumor suppressor gene. This is correct. Answer is E. Both familial polyposis coli and Gardner syndrome are autosomal dominant. So autosomal recessive वाली कोई बात नहीं है. The allelic deletion of putative tumor suppressor gene located on 5th chromosome segment Q21, Q22. The FAP is an autosomal dominant disorder causing extensive adenomatous polyps of the colon and early onset colorectal cancer so early as 20 years of age. Quantitative and qualitative alterations in gene expression accumulate in the colorectal cancer cells. Now, these include alterations in multiple gene expressions and chromosomal abnormalities like deletions at 17p, short arm of 17, long arm of 18. They are seen in 70% of colorectal carcinomas. Then comes the Peutz-Jeghers syndrome. As we discussed, it is a benign disease, rarely undergoes malignant change. Dominantly inherited. Dominantly means again autosomal dominant. It has got pigmentation of skin and mucous membranes. There are polyps in stomach and larger intestine, which are basically hematomatous in nature. And as we discussed, colon cancer ke liye rectum and the sigmoid are the commonest sites, not the ascending colon. Any questions here? No? Okay. A 35-year-old gentleman comes to you with a distinct thyroid swelling. Okay, so thyroid swelling, a very big chapter, a book can be written on thyroid. So theoretically, thyroid swelling can be a cyst, it can be a nodule, it can be a malignancy or a cancer, adenoma, or a carcinoma. Nodule can be cancer, can be benign. So usually you can do it from radioactive iodine uptake. If they are usually the cold nodules are malignant. Cold nodules are malignant. So a 35-year-old gentleman comes to you with a thyroid swelling. An isotope scan reveals that he has a cold nodule. So we just discussed that cold nodule are malignant. Along with that, he has local cervical lymphadenopathy. So the lymph nodes are there in the neck. Which one of the following is a plausible diagnosis? Is it Graves' disease? Is it anaplastic carcinoma? Is it papillary carcinoma? Is it medullary carcinoma? Or is it subacute thyroiditis? Can you tell me what is this question about? Can you get the essence of this question? What is this? What are they asking about? Basically. So basically they are asking about the epidemiology of the thyroid cancers. So they've randomly thrown question at you that a patient has come with a thyroid cancer. Which is the most common thyroid cancer? This is the basic question.
Yeah, that is papillary one.
Yeah. So the answer will be?
Papillary carcinoma.
Great. So the answer is papillary carcinoma. How do we know the answer? Because of epidemiology. That if somebody walks into your clinic with a, supposedly thyroid cancer with lymphadenopathy in the neck, the answer is going to be papillary carcinoma because it is most common. We have three cancers here: anaplastic carcinoma, papillary carcinoma, and medullary carcinoma. So all of them present in a different manner. So what you see here is that papillary carcinoma is the correct answer. It makes up for 75% of the thyroid tumors, and this patient's age under 45 puts him in a low risk group, although. But if they are cold nodule uh, and there is an intraglandular spread or local lymph node invasion, you can diagnose them as having papillary carcinoma thyroid. They are slow, but they can become aggressive, spreading locally or metastasizing, especially to lung. So the next question that can be asked is, the person is concerned about the metastasis of this carcinoma. Which of the following organ is most important as far as the metastasis of thyroid cancers is concerned? So the answer will be lung.
Lung.
Okay. We are still on this thing. So medullary thyroid carcinoma, it originates from C cells rather than thyroid epithelium. So they release a tumor marker or a protein known as calcitonin. So calcitonin is a tumor marker in these cases and also occurs in the setting of men type 2. So in men type 2, you will have other histories also. Familial history will be there, and the patient will have either some parathyroid lesions or pancreatic lesions or something like that. So they will tell you about those things as well in the exam. In the decreasing order of malignancy and frequency, increasing malignancy and decreasing frequency, you see papillary, follicular, and anaplastic. So PFAN. Papillary is most common, follicular is second, and anaplastic is least common, but it is the most destructive, the anaplastic one. It is most malignant, kills very fast. Anaplastic C is most aggressive and usually seen in elderly people. As far as thyroiditis or Graves' disease is concerned, that's totally a different topic. Okay. If you just look at this, this is the question that usually comes in the exam. It is the analysis of patient with a thyroid nodule. So the step number one in the management of thyroid nodule is that you do a fine needle aspiration. If on fine needle aspiration you do not get a sufficient sample, you look at the left side, then it is a non-diagnostic. You repeat the FNAC. So the question can come in the exam that the patient has already got FNAC done. So what is the next step? So the answer is that you repeat the FNAC. Now, if the patient has malignancy proven on fine needle aspiration, the treatment is surgical removal, that is thyroidectomy. If there is any suspicion of malignancy, again surgery is indicated, thyroidectomy. If convincingly the report comes benign, then you must follow the patient. These are papillary adenomas which get converted into carcinoma at a later date. Then you can differentiate papillary to another tumor which is microfollicular. We call it follicular neoplasm, which are very, very intriguing as far as the thyroid professionals are concerned, because follicular neoplasm can behave in a secretory adenoma like fashion. So it can lead to hyperthyroidism where TSH will be low. You perform a thyroid scintigraphy. In scintigraphy, if it is a non-functioning, that is a cold nodule, you perform surgery and remove it. If it is autonomous, then you can follow or treat. That means it's a hot nodule. If the TSH is normal, again you can do a surgery or consider scanning. If it is non-functioning, always remember, any non-functioning cold nodule has to be removed. Chapter closed. If it is not functioning and is there, You've done the biopsy, you find out something different, and it is not functioning. How do you get the functioning? From the radioactive uptake scan. If the radioactive uptake scan tells you that the patient has a non-functioning or cold nodule, remove it. If it is a hot nodule, only then you can sleep with a relaxed mind. Otherwise, you cannot. If it is a follicular lesion or atypia due to undetermined significance, repeat this test again after some time, 3 to 6 months. It will come positive, and then you will remove the tumor. Is that clear? The evaluation of thyroid nodule. The first step that you do in thyroid nodule is perform a ultrasonography of the neck. Second is, of course, you perform a FNAC. After FNAC, you perform a radioactive iodine uptake. Is that okay? Or you can do it earlier also. You can do it simultaneously as well, so that you have a convincing data. If the uptake is cold, FNAC showing follicular, microfollicular, remove it. If it is hot, continue treatment, or observe it and repeat the scan, repeat FNAC 3 to 6 months. Is that clear?